sir and Nikhil Gokhale sir. And from those 17, we have chosen the best of the best three. And they will be presenting today here in the main conference. So, with the permission of the chairman, can we start the presentation, sir?
Yes, please do.
So the first is Dr. Zahin Khatib. He is a winner of Dr. T.P. Lahane Award of BOMOS Focus. Very congratulations, Dr. Jain.
Thank you.
Zain, hats off to you.
Thank you,
Better
sir. Thank
lovely.
you.
Keep up the good work.
Congrats, Dr. Zain.
Thank you. Thank you, sir.
He does the standalone practice and in a single specialty, and he did a very good study, and he presented also very well. So all the judges gave him the maximum marks, and he is the topper of us.
Dr. Zain also has been consistently winning awards at the MOS conference. Because last 2 years when I was scientific chairman, I know giving him many awards. Congrats.
Sawant,
Thank you,
Preetham, Preetham, if it was like that, पहला बोलना था ना, so we would have given another one a chance here.
So neutrality.
अच्छा.
MOS का award sir अभी तक मिला नहीं है because of the delay in the conference. Hopefully this year.
Yes.
Ravi Jiti. Then over to you. You can make it full screen.
Okay. At the outset, I would like to thank BOA wholeheartedly for recognizing my study and awarding it to all the judges, to the organizing committee, everyone. So this is the third time I'll be presenting this. And since, it's not going to be a competition anymore, I may, be presenting it slightly differently. So my study was basically another study, just like a structure function correlation between an OCT machine and a perimetry device, which has already been studied extensively for glaucoma diagnosis and progression before. But what we did is we used the octopus perimetry this time. And although octopus perimeters are standard perimeters, but their use has been underreported due to the widespread monopoly of the Zeiss Humphrey, which is most often used for research purpose. What makes the octopus so special is that it's got a G strategy, which doesn't just randomly test the points, but it tests these points along the RNFL bundles. And it gives double the points in the macula, which are more susceptible to glaucomatous damage. When you talk about the OCT devices for glaucoma analysis, the OptoView and the Zeiss Cirrus have been time tested for glaucoma, but there's not much literature on using other OCT machines for glaucoma. So in our study, we aim to compare the structure function relationship of corresponding RNFL thickness by a new SD OCT machine versus the octopus perimeter, a software called as cluster analysis in normal and glaucomatous eyes. So the machines tested are the octopus 600 perimeter versus the Octopol Revos 60 OCT, which is by My Healthscape. So in the octopus perimeter, we took a specific software called the cluster analysis. Now, this cluster analysis probably may not be familiar with everyone. What cluster analysis does is it categorizes all these points into 10 RNFL sectors, into 10 RNFL clusters, and the mean deviation in each of these RNFL clusters is averaged out and you get a single value. So you basically get 10 mean deviations for 10 RNFL clusters. And if you look at the Revo OCT machine, it also gives you 10 OCT RNFL sectors. So what we did in this study is we tried to spatially correlate the RNFL sectors on OCT versus the clusters on perimetry. And we tried to see if these match. So we, try to identify which fibers each one supplies. And this is what we did. And so what we did is we numbered all the sectors and clusters sequentially starting from the nasal side. And just to give you an example, so if you take sector 8 and cluster 8, so in this example, you can see the OCT is telling us that the RNFL thickness of sector 8 is 97 microns, whereas the cluster analysis is showing 4.5 diopter mean deviation in cluster 8. So this was the correlation, and this is what we tried to test. So we took patients aged between 18 to 70 years prospectively who needed perimetry and OCT testing. The patients were divided into cases which were glaucoma eyes and the normals, which were the controls, which were the normal eyes. And any patient with non-reliable perimetry, poor OCT quality scan, and other coexisting pathologies besides glaucoma were excluded. And all patients underwent detailed clinical and glaucoma evaluation and the glaucoma was defined as per the previous literature. So the primary outcome measure was to test the correlation between each OCT sector and the corresponding perimetry cluster. And this was given by Pearson's correlation coefficient. More than 0.6 correlation was considered strong, 0.3 to 0.6 was considered moderate, and less than 0.3 was considered weak. We also wanted to compare the strength of association between each OCT sector and corresponding perimetry cluster. And this was given by linear regression analysis and presented as beta coefficients. The secondary outcome was to see the predictive value of each OCT sector. So what is its probability of getting a significant field effect in the corresponding cluster, and what is its ability to predict the occurrence of glaucoma? And this was done by logistic regression analysis and receiver operating curves. So when we look at the results, we had 100 eyes, out of which 52 were glaucoma and 48 were normal. Now these eyes were matched in every way except the age. So age, there was a significant difference between the two, where the normal eyes were younger as compared to the glaucomatous eyes. And this is a table showing my primary outcome measures. So on the left side, we can see the correlation analysis. On the right side, we can see the linear regression analysis. So we can see that sector 2, 3, 4, 7, and 8, they all showed significant correlations, out of which 3, 4, and 7 showed strong correlation, whereas sector 2 and 8 showed moderate correlation. And if we look at the association along with these 5 sectors, even sector 9 showed a strong association. The strongest association given by linear regression was in sector 3, which tells us a 2.71 micron reduction in RNFL thickness is seen with a 1 mean deviation increase in the corresponding cluster. Now, the secondary outcomes, the receiver operating curves, they tell us, a cutoff value for each sector, how sensitive and specific it is to pick up a significant visual field effect and to predict glaucoma. So again, these 6 sectors, 2, 3, 4, 7, 8, 9, these all showed significance, out of which sector 7 and 8 showed the strongest sensitivity and specificity to pick up glaucoma and also to pick up a significant field effect. So basically what our study showed is the sectors 3, 4, 7, 8. These actually constitute the arcuate fibers. These showed strongly significant results in terms of correlation, association, and predictive value for glaucoma. The sectors 1 and 10 are the nasal radiating fibers. They showed no correlation, while as sector 5 and 6 constitute the papillomacular bundle. These also showed no correlation. So out of the 4 sectors I spoke about, the inferior arcuate fibers, that is sector 3 and 4, they showed the strongest correlation and association with the corresponding field effects, while the superior sectors 7 and 8, they showed the strongest predictive value for glaucoma. So almost 80% sensitive. So what we could say is that a sector 7 value of less than 106 microns and a sector 8 value of less than 130 microns was highly suggestive of glaucoma as per this study. So to conclude, RNFL thickness on the Revo 60 correlates well with visual field analysis on octopus perimetry, and the machine is capable of independently and accurately predicting glaucomatous visual field effects and glaucoma diagnosis. So I thank you, and I would really like to acknowledge Sengupta Research Academy and Dr. Sunny Sengupta for helping me with this study. So as Dr. Lahane mentioned, that I'm into private practice and have my own solo practice. So, research is something that doesn't come naturally to us, but because of SRA, I really, managed to get all this data and analysis. And for all private practitioners out there who want to do research, and, it's not impossible to do a proper good study with good methodology, because we have, Sengupta's Research Academy, and, it really helps. So thank you.
Great. It was a nice paper, Zain. I think, in today's times where, where time is so precious and important, to get these kind of studies correlating perimetry, which is such a laborious investigation versus an OCT, and have this kind of a scientific correlation to show that you can pick up glaucoma and treat it even based on OCT. I think this is definitely a good study. Yeah, Dr. Paresh.
So if somebody doesn't have both the machines, if they have only one machine, is that good enough to pick it up?
As per the study we have done, it's kind of saying that it can be used to pick up. So what we did is we wanted to test the OCT because it's untested versus perimetry, which is tested. So our study kind of says that you can use the OCT individually also to pick up, even if you don't have the perimetry, based on the results.
So those with OCT can rest, be assured that it will give almost equally accurate results.
Right.
I just have a question, Zain. Why were the patients not matched for age? Your
Sir, the matching of the patients for age is really difficult because most of the glaucoma patients are bound to be older as compared to normals, because it's not like we selected normals randomly. They were patients who needed perimetry and were found to be normal also. So it's not like we specifically selected. We prospectively selected normal and glaucoma, and those who turned out to be normal were actually included, and they turned out to be younger.
It's basically glaucoma versus glaucoma suspect.
Right, exactly.
Sunny wants to make a point. Please unmute yourself.
Yes, hi everyone. So I think to answer Dr. Parikshit's question is a great question. And if somebody has a thickness of less than 105 microns in that sector 7 and less than 130 in sector 8, then there is 80% chances that he has glaucoma. So that is pretty much sort of the one line take home if somebody is only using this machine for detection of glaucoma.
Right.
Thank you.
Thank you, doctor.
Wonderful.
Thank you, Zain Gupta, sir. That was really can say that your academy has benefited all. Like we are one of them, and we keep attending your lecture. And thank you for being there for us and keep motivating through your emails and your lectures.
Yes, please keep up the good work.
Thank you. Thank you.
Move on to the second, first runner-up. Basically, the first runner-up is Dr. Saili Garge, and she will be talking about her next generation cross-linking calculator for titration of ultraviolet energy in keratoconus. Dr. Saili, can you introduce yourself in one line and then start?
Yes, sir. I am Dr. Saili Garge. I am a cataract and refractive fellow in Narayan Netralaya, Bangalore. So today I'll be presenting a new application which we have devised for energy titration for the cross-linking of thinner corneas. So first of all, good afternoon, everyone. I would really like to thank all the judges for appreciating my presentation. And I would like to start. In the current time of COVID-19 pandemic, there is a paucity of corneal tissue. Thus, there is an increased need for cross-linking to save the thin corneas from progressing further. So what are the treatment options available to us? The current treatment modalities have been previously well established. A simplified 5-point management algorithm for keratoconus is used in current practice. A 18-year-old male patient with chief complaints of frequent change of glasses and diminution of vision in both eyes. His best corrected visual acuity was 6/24 in the right eye. On slit lamp examination, ectasia and both stria were present. No scarring was noted. His retinoscopy showed scissoring reflex and high cylinders in both eyes. His topography showed advanced disease with thinnest corneal thickness of 390 microns. So how do we proceed in this case? Do we go ahead with standard cross-linking in this patient, or do we post him for keratoplasty? So this led to an idea floating in our minds. Is there a simpler way to titrate the energy and time? Our team of researchers have proved an algorithm which predicts the biomechanical effect of cross-linking by customizing the UVA fluence to the corneal thickness after taking various parameters into account, like the UVA intensity, the riboflavin concentration, and the time, and concluded that cross-linking is more dependent on the duration of the UVA light than the overall applied UVA fluence. Thus, we developed an application known as the NXT UVA calculator, which gave us the fluence time for different corneal thickness, which can be easily used by the clinicians. This application gives us the fluence time according to the epithelial of corneal thickness and to its corresponding UVA fluence time at 3 milliwatt per centimeter square and 9 milliwatt per centimeter square. So how did we manage a patient with advanced keratoconus having thinnest corneal thickness at 390 microns and epithelial of thickness at 340 microns? These values were entered in the application, which gave us the UVA fluence time of 21.95 seconds at 3 milliwatt per centimeter square and 7 minutes 30 seconds at 9 milliwatt per centimeter square. 0.1% riboflavin drops were instilled every 2 minutes for 20 minutes, followed by UVA light for 7 minutes and 30 seconds at 9 milliwatt per centimeter square. Thus, the UVA fluence time was customized according to the need of the patient. We studied 50 eyes of 45 patients of progressive keratoconus with documented progression, total corneal thickness of less than 400 microns, and no scarring. Patients having active ocular surface allergy, corneal scarring, previous history of collagen cross-linking, and pregnant patients were excluded. All the patients were assessed pre- and post-operatively for the surgical outcome. Pre-operatively, the corneal topography, epithelial mapping, and specular microscopy were done. NXT UVA algorithm was applied and cross-linking was performed accordingly. At 1 month, 3 months, and 6 months of follow-up, the best corrected visual acuity, corneal topography, specular microscopy, and anterior segment OCT were repeated. Demarcation line was documented in 65% of our patients at the end of 1 month. There was no significant haze noted on pentacam densitometry and clinically as well at the end of 6 months. There was no statistically significant change in the endothelial cell count pre and post procedure. None of the patients had loss of lines on the Snellen's chart. The efficacy was established by a stable keratometry at 6 months. Polarization sensitive OCT, which helps us to study the collagen orientation and density in cornea, showed either the collagen orientation was better or there was no change post-procedure. 65% post-op patients had no biomechanical weakening and 35% patients showed stiffer biomechanical response. So what we saw was there were good clinical outcomes and with stable topography, presence of a demarcation line, and no clinically significant haze. To conclude, what was known earlier was that standard cross-linking is not possible in treating the keratoconus patients with thinner cornea. Various alternative treatment options are available, but they have their own limitations. Our innovative app removes this barrier of 400 microns while still respecting the safety restrictions. Our calculator is a simple and freely downloadable application for everyone's use. This application will be an invaluable tool for delaying the need for a transplant in thin cornea. Long-term follow-up and patient cohort are some of its limitations. This application can be downloaded by scanning the barcode. Thank you so much. Thank you, sir.
Great, very nicely presented, Dr. Saili.
Thank you.
You did mention in your last slide that a lot of long-term follow-up will be required. So
Yes.
what is the mean follow-up you have on all patients? Probably you can give us a range also.
So right now the study is still an ongoing study. So we are actually doing the study since 1.5 years, but we have lost few patients in between due to COVID. So right now we have done the statistical data analysis of 6 months as of now.
Okay.
And it's still an ongoing study. We are about to publish a paper maybe in couple of months.
All right. No, very, very well done.
Thank you.
Congratulations.
Thank you.
Very good study.
You can stop sharing your screen, Dr. Saili.
Yes, yes.
And we have a second runner-up here now, is Dr. Monisha Apte.
Good evening, everyone.
And hers is unusual case of metallic intraorbital foreign body. You can start sharing your screen.
Yes.
So, sir, we had a lot of case series, case reports, original studies, and even case reports also. So this is one of the case report which has superseded the rest of the case series and other. So we can imagine how great it is, and it was done here in the Sion Hospital. Now,
Yes.
Dr. Monisha presently is in Delhi, correct, Dr. Monisha?
Yes, sir.
Please start your presentation.
Good evening, everyone. I'm Dr. Monisha Apte, and thank you, BOA, for giving me this opportunity to present this case. Also, greetings from our department to all the respected judges. So I had done this case with my mentor, Dr. Nena Poddar, and Dr. Shinde ma'am. So I'll be presenting an unusual case of metallic intraorbital foreign body removal and integrated approach. So a 16-year-old male had been referred from a primary health center to our casualty with an accidental trauma to his right eye with his own kada, which was a metallic wrist brace while playing volleyball. So while ducking the volleyball, he accidentally hit his eye with his own hand. And then patient came to our hospital with an intact brace, which was stuck firmly below his right eye since 12 hours, causing pain and swelling. So as we can see on external examination that the end of the kada was seen entering through the lower lid, causing a linear 3 centimeter by 1 centimeter entry wound with surrounding soft tissue swelling. The other end of the brace was seen resting over the skin temporarily. So the vision of the patient was 6/6 with a near vision of N6. There was no apparent globe rupture on examination. The pupils were normal sized, reacting to light. Ocular motility was painful in the inferior gaze. However, it was full and free in all other gazes. Fundus examination was within normal limits. There was no infraorbital nerve anesthesia, and palpation of the bony orbit was painful because of the kada. So an X-ray orbit was done for screening along with a CT orbit and a 3D reconstruction of the midface, which showed a linear undisplaced fracture in the lateral wall of right orbit. As you can see that the foreign body was about 15,000 Hounsfield units, which was lying along the floor of the orbit, and the end of the brace was impacted at the junction of the floor and the lateral wall of the orbit. So the 3D reconstruction of the midface showed the orientation of the foreign body with respect to the surrounding structures. So we braced ourselves to remove this metallic brace under general anesthesia with plastic surgeon and ENT surgeon on standby. So what we had done initially was we extended the entry wound like a subciliary incision for a better exposure. With blunt dissection, we dissected the shaft of the foreign body from the floor of the orbit and periorbita. The difficulty faced in this case was to remove the foreign body in toto, which was not possible because the knob was impinging at the junction of the lateral wall and the floor of the orbit inside the bone. Also, the foreign body could not be pulled out by any force because of the restriction of the movement by the zygomatic bone outside. Thus, removing it would have caused damage to other structures. Hence, we decided to cut the foreign body into two halves using an H-rod cutter. An H-rod cutter is an instrument used in orthopedic surgeries for cutting K-wires and shank spins. So by cutting the foreign body into two halves, the stuck fragment could then be easily pulled out from the orbit, as we got a vector to pull it so. So this was the part which was lying inside the orbit, and this was the knob which was stuck inside the bone. So the knob was measuring roughly around 5 millimeters. On inspecting the cavity after removal, we found a circular defect in the lateral wall of the orbit. Also, there was a unicortical fracture in the inferior margin extending up to the infraorbital foramen. So we took a plastic surgery consultation on table where we decided to manage the fracture conservatively. The infraorbital nerve was intact. Force reduction test was normal for all muscles, especially the inferior rectus muscle. The wound was thoroughly clean, and the periorbita and orbicularis was closed with 6-0 vicryl with the skin closure done with 6-0 ethylone. Post-operatively, the patient had a best corrected visual acuity of 6/6 with a near vision of N6. The sutures were intact. The wound was clean with no oozing or bleeding from the wound. The ocular motility was full, free, and painless. Hence, we put the patient on an oral antibiotic cover and non-steroidal anti-inflammatory drugs. So we can see that ocular injury is a major cause of treatable visual impairment and blindness. Sports and recreation itself account for about 37 to 52% of ocular injuries. These injuries mainly affect young children in 58 to 70% of cases. So in literature, there is a table which shows sports classified as high risk, moderate risk, and low risk of injuries, where in our case, volleyball comes under moderate risk of ocular injuries. These are certain signs and symptoms requiring immediate ophthalmic referral, where in our case, an embedded foreign body was the reason which prompted emergency removal. How to manage such cases? Using protective gear during playing is mandatory, because 90% of injuries is preventable by doing that itself. However, in our case, this would not have been possible because such injury was rarest of the rare case, and the impact by which the patient was hit was very hard, because of which the entire kada got stuck into his eye. However, while playing, if we don't use ornaments, then definitely such injuries can be prevented. Also, we have to use multiple specialties of expertise in tertiary referral center, because each case is rare in presentation, and for every individual, such approach has to be tailor-made. Also, prompt and effective management with removal of the foreign body at the earliest is mandatory, because this will prevent complications such as blindness, intraorbital and intracranial infections. What was unique in our case? Despite the foreign body being so close to such important structures around it, there was no damage to vital structures. The patient possessed good postoperative vision because the optic nerve was intact. Also, there was no globe rupture. We adopted a multidisciplinary approach for removal of the brace. Also, removal of this brace in this case was challenging because of its peculiar shape, lodgement of the tip deep within the bone, the proximity of the kada to the globe and surrounding structures and sinuses. Thus, the take-home message in my case is the effectiveness of timely intervention using multidisciplinary approach in a tertiary care center, which will help aiding better postoperative cosmesis and visual outcome. These were some other examples which were managed in our case, where in this case, during Diwali, the patient got hit by an acrylic foreign body by bursting cracker in a soda bottle, and thus the eyeball got displaced in the maxillary sinus. Thus, with the help of ENT, we put a Foley's catheter and brought the inferior wall of the orbit up by inflating it so that the floor remains intact. So this is how ENT and plastic surgery played a role in this case. Similarly, in the other case, the patient got stabbed by a knife, which caused this knife traverse till the other orbit and cutting the optic nerve of the other eye. So we used an endoscopic approach for removing the knife, and thus the vision could not be salvaged. However, the knife was safely brought out of the orbit by not damaging other structures. So thank you.
A wonderful case presentation.
You can stop sharing the screen now.
Very nice. Penetrating ocular trauma and ocular, traumatic emergencies is always a very interesting branch of ophthalmology. It can, it can spring a lot of surprises and can bring out the surgeon in you. So nice case. Very nice. Well done.
Thank you.
Monisha, this was a very good case. Very good case. Appreciate it. Very good case.
So, since all the office bearers are here, both the president, secretary, and Lahane sir, we can virtually at least present the certificates to all our winners. So, Sai sir, ready?
I'm showing up.
Yeah.
Sai is like a magician who conjures up things.
Amar is there?
Yeah,
Dr. Amar?
Yes, we can see him. He's there.
Dr. Amar is there?
Dr. Amar sir is there, sir.
So this is the second runner-up award of Dr. T.P. Lahane, presented to Dr. Monisha Apte by Dr. Parikshit Gopte sir, Pritam Samant sir, Lahane sir, and Swapnit Samant sir. Congratulations, Dr. Monisha.
Thank you, sir.
Great presentation. Keep going.
It was not possible without my department, without guidance of my mentors. So, yeah, thank you, sir.
Then next certificate, Sai sir. So the first runner-up of Dr. T.P. Lahane Award is Dr. Saili Garge for her innovative study on keratoconus and cross-linking, and her virtual certificate is presented to her by the MOS and the BOA President, Dr. Parikshit Gopte sir, and the Pritam Samant sir. Congratulations, Dr. Saili. Very well done. Keep it up.
Thank you, sir.
Congratulations, Dr. Saili. Congratulations.
Thank you, sir.
And the winner, please. And the Dr. T.P. Lahane Award for BOA 2021 goes to Dr. Zain Khatib for his innovative paper on the study of OCT and perimetry, and this certificate has been presented to him by all our office bearer and Dr. Lahane sir. Congratulations, Dr. Zain. Very good
मैं अभी
study.
expect करता हूँ वहाँ से
Congratulations. Very well done.
मैं पेमेंट में जाता हूँ
Congratulations,
पेमेंट में
Dr.
जाता हूँ पेमेंट में मैं
We had all India participation here. We had got more than 200 papers, 160 presented. Out of that, 17 were chosen best paper, and 3 best of the best have been selected after 3 weeks and multiple rounds. So, congratulations to all the winners.
Congratulations, Dr. Khatib, Dr. Zain Khatib. Congratulations for all the winners.
Congratulations, everybody.
Sir, and one person we have to thank and congratulate for all this. Sapnesh, you do the honors of congratulating and thanking.
On behalf of the President of BOA and the President of MOS, we thank Dr. Lahane for being the backbone of this free paper session from day one. And not only the free paper session, but also the entire conference. He has been the man behind the curtains, working day and night.
Mohan Rajan.
Thank you, sir. Thank you for all the opportunity.
But it is a fact that Sumit has worked tirelessly, and all the judges. I must salute all the judges. And Mohan, thank you very much for joining.
Sir, how can the genes
and
go
really,
wrong?
I'm happy that the Ragini, then the Swapnis, Sumit, Pratham, Parikshit, they are really done wonderful work. Wonderful. I salute you all. And Ranjit, thank you very much for all this free paper session that you did it. Thank you and congratulations to each and every.
Pleasure.
Sir, genes cannot go wrong, sir.
Thank you.
Amar, yes, Amar. I was just saying that Amar is not there, so Amar has come. See what happens. Few people are my inspiration. In that, Amar is there. He is my inspiration.
Sir, the work you are doing is something phenomenal, not only for BOA, MOS, but for India as a whole through this Corona war, which you are fighting single-handedly with the government is fantastic. Every time I see you on national television with all these ministers and all, I'm so worried about you. I tell Ragini every time, please be careful because there is so much of COVID all around there.
You're worried for Lahane, sir. We are worried for the ministers.
Pritam,
Nothing will happen to
spot on.
sir.
Pritam, spot on.
Hi, Pritam.
Amar, बहुत अच्छा लगा. I'm very happy that I saw you. I'm very happy. बहुत अच्छा लगा. Kumar, thank you. Thank you very much. I think
Our best wishes for you, sir. We are all with you.
You will have to work, Mohan. You will have to work.
Absolutely, sir. Absolutely.
Thank you. Okay. So I think session.
वेळ आहे ना अजून थोडा वेळ आहे की नाही
Mohan,
10 minutes.
Mohan, your team will go first, okay?
Yeah, fine.
After entertainment, there will be science.